So very welcome on this afternoon. I want to talk about the IMCAS alert, and I want to give you an attraction, why you should join our group. First, that we created this like 7 years ago. It was Benjamin, me, and Sebastian. And what you see here, these delicate two guys on the other side, like Ron, he's sitting beside me, and Fadi, they are joining this since many years now and are very important contributors to this session. And in the middle, it's not just only Popeye from Bangkok, it's also Hugues Cartier, who was also in the IMCAS alert group. So have fun with the IMCAS alert and please come and join us. Why did we create this? Because if you go to the internet, you see all those complications popping up. And of course, no one is safe from complications, so it might happen to you as well. And then it comes this. And what do? You're just sitting desperately and you say, so what can I do? All right, I have to call somebody. But who is this one? And this one is us who are sitting here. On the other hand, it's if you think about going to the university hospital with a complication case, you can count hours until somebody will take care about you. And probably it is the youngest surgeon who has never dealt with complications, so it will take even a couple of hours. So that's why we created in the last 2 years this IMCAS alert group. These are the coordinators. Now we have 2 more in our group. And another aspect why we created this is this Otto von Bismarck, a German chancellor. And he says, only a fool learns from his own mistakes. The wise man learns from the mistakes of others. This is also why you should join us, because this is a learning platform for you. To learn from our mistakes, from the mistakes of others, without charging them, because you have to deal with it, and anyone will have complications, even the most experienced one. And then it's good to have someone in the background you can ask. We created IMCAS alert. We have 5 groups. The biggest one is the injectable threads group. Then we have the surgical group, which is the smallest group, because surgeons never have complications and know everything. But nevertheless, let's go into it, how we work and how it goes. You go in the IMCAS platform, imcas.com, and you will get the answers from all the panels here. And these are very specific answers. These are discussions, and you will get the information immediately. You go on the academy, and as soon as you go in the academy, you go into IMCAS alert. Guillaume, I don't know if we have a new one now. Probably this is the guy in front. He knows everything about the new platform. And then you go for the injectables. Now it looks a little bit different, but it works the same. You have a problem, you post it, and then we count it. And we can see that immediate answers are around 20 minutes after you posted the case, 20 or 30 minutes. Can you imagine? When you post the case and you get want to have an answer, can you imagine you go to the hospital to get in 30 minutes an answer, which might be helping you? And all what we can say, you have to deal with, if you have to deal with complications, it has to be, most of the cases, quick. If it's really severe cases, you want to have a quick answer and a quick help. So this is how it works. You say, I have a problem with the lips, what I did. You have to describe the patients. You have to describe the procedure you did, and then you submit the topic. And in the end, you got the answers. As I said, most of the cases in between 30 minutes. So this is really a service which is provided by our group and IMCAS Academy. So this is the surgical group. Chairman is Fuad Nahai, most known plastic surgeon, really famous. And I want to show you how it works. So someone has a vascular occlusion with radius. The author is from the United Emirates. It says, okay, we have this problem, what did I do? And after that, there come immediately answers. So 8:35, he is never sleeping, I think. He has his computer all the time on, because he's almost the first one. You can believe under us, it's like a run who will be the first to answer. So you have almost the computer on to be the first, and Fadi is the second one. So they're almost matching who is the first answer and who is the second one. But nevertheless, First answer 8:35, second answer 8:57. So you have the superstar answers in between 1 hour. Can you believe this? You go to the hospital? No, no way. And then next one, Fernando Silikovic. So the first came from Australia, the second one from Palestine, the third one from Argentina, and the next one again Palestine, New Zealand. So Israel, you have all the answers all over the world, the expert panel. So which means there's always one person awake to help you, no matter where you are, where you have the problem. IMCAS report 24 was created by our friend Guillaume, and it says what is and how often do you check the IMCAS alert forum? So it's several times a week, once a week, and daily. This which sentence best describes it? I'm reading discussions a lot, but I don't really post myself, and that's why I tell you it's a learning platform for you. About the satisfaction rate, enormous, huge satisfaction rate. So this is really also a service which is provided without any cost. It's anonymously, it's without any cost for you. You just join and you post the cases. And what would you like most of the alert? Getting the replies by world-class experts, and also respectful, honest, and non-judgment discussion. The one who has dismissed this and is not that with respectful, we had a discussion. He's not anymore in the group, and I think we removed him. So respectful discussions, because you're in trouble, you have a stress, your patient has a stress, and we want to help you out. So to conclude this, the creation of the alert group stands for improving safety and education on an outstanding high level with underlying publication citations. So it's almost underlined. All in this alert project involve colleagues are key opinion leaders and world famous expert and best known speakers. It's a non-profit group which gives their help for free to provide a maximum of safety and quality. And now it's 8 years after founding the alert group. We're over 5,000 cases we have discussed and leading to problem solutions. So what we want from us, you want you as a physician, we want you as a member, we want you as a speaker, and we want you to be a friend. So come and join us, and probably we can discuss in Paris next year, January, a little bit more about this topic. Thank you very much.
Can we make that larger? Can we make that larger? Can we make that screen larger so I can see? So I can see that better. No? Okay. Okay, well, Thomas, thank you very much for welcoming the session. And I think at this point we might also introduce our panelists. Over on the far side we have Steve Weiner from the Dr. Steve Weiner, facial plastic surgeon from the United States. We have Dr. Leonie Schelger from the Netherlands, and she's an aesthetic physician and phlebologist, and I'll give you some further introduction. We have Dr. Rosa Sigris from Brazil, not Argentina, Brazil, and she's a radiologist dealing with complications day in, day out. We have Dr. Maurizio Saron from Germany, and he's also an expert ultrasound guy and cosmetic surgeon. And Dr. Won Lee is a plastic surgeon from South Korea. So welcome to our panel, and Dr. Maurizio will also be speaking. Now I want to just point out that on this panel here, we have some of the most respected ultrasonographers in aesthetics in the world. So right before you now, and I see Roy is down here as well. So we have an amazing, I don't think it's coincidental, I don't know, but it's, you know, we have people here who are terribly experienced in complications, and so thank you very much for attending. So my talk is regrets I've had a few. I'm unconflicted in my talk. I tried to ask people to conflict me, but nobody came up with any offers. So regrets I've had a few, and I think failed and discarded treatments, and that will segue into IMCAS alert. So we'll move the slide forward. Not moving forward. That point there. Okay. So, no. Can I use that? Okay. So, I'm Ron Feiner from Sydney. I'm on the IMCAS alert expertise. I think we won't go through the slide. Dr. Rappel has gone through about the way this functions. And so these are now the collection of IMCAS alert coordinators, and it's quite a group now of experts, and we're very grateful for their input from all sorts of different disciplines within medicine. So regrets.
I've had a few, but then again, too few to mention.
Well, I think we've all had regrets. When we're doing this work, we're going to get complications, as my panel knows, because they're all involved in complications with ultrasound. And the complications are lead to people discarding some of the procedures. It can be very disheartening. But in fact, when I went through scores and scores of cases, and I think MCAS alert's been going since about 2017. It's quite some time. So I went through a lot of cases over the last 9 years or so, and I was surprised that a few treatment modalities could be now considered discarded, but not too many. Maybe some of them are like human and bovine collagen injections, permanent fillers like silicone, polyacrylamides, Gore-Tex implants, non-fractionated ablative CO2, although some people still do it. Vampire facelifts, you remember when that was the craze a long time ago? It was crazy. That's sort of been discarded, not PRP per se, but some of the sort of bloodbath type procedures. Traditional derma sanding, I think, has moved on, and then there may be others, but there's actually not that many. Some of these things survive for a very long time. And the reality is that there are many other factors at play apart from obsolete product technology, naive practitioners in anatomy, product suitability, aseptic technique, poor placement, insufficient appreciation of the layered ligamentous and retinacular anatomy, and limited treatment repertoire. We all know about Maslow's hammer. If the only tool you have is a hammer, you tend to see every problem as a nail. And so you have to have a treatment repertoire, and you have to be able to say to patients, no, look, I don't do the appropriate procedure that you might need, and maybe pass them on to a close colleague that does. Inappropriate patient selection is something that we must avoid, not committing people to something they shouldn't have done, and also unrealistic patient and physician expectations. Remember, there is no such thing as a minor procedure if there's a potential for serious complications. And though treatments are generally safe, complications can occur even with excellent practitioners. And these include bruises, hematomas, neuropathy, infection, scarring, nodules, granuloma, tissue necrosis, and there are rare and more and serious complications such as blindness and stroke that we all fear. So it's very important, to avoiding regret, to remember ethics, the Hippocratic Oath, which has got nothing to do with hippopotamuses, but it has a lot to do with the tenets of medicine, doing the right thing. And I think that's very, very important because, again, you have to learn to know when to say no. But happiness can turn to misery. You know, we love this field. Everybody here gets results and they feel so good at the end of the day. It's great. Look what I achieved. It's just wonderful. But that can turn to misery when something goes wrong and you have a complication. And you know that as doctors, we have this gut-wrenching introspection when something goes wrong. You know, it really gets to us, and that lasts for about 10 seconds, maybe 5 seconds in a surgeon, and then we start to blame our assistant and our nurse and the weather and climate change and your spouse. You start to blame everything else but yourself. So it's very, very important to have something that you can rely on. And when we encounter an alarming complication with a product or a technology, there can be a response that inclines towards discarding it. And that's where IMCAS Alert comes in. Because rather than discard a procedure, ring up the company and say, look, I've used your product, it's terrible. And they say, well, we've had 2 million cases in the last year and nobody rang up with a complication. You must have used a counterfeit product. It can't be us, but put a report in, goodbye. But we have IMCAS Alert, and as Dr. Rappel pointed out, we're there to help you. And there's a large group of collegiate people who are there for you. And it becomes really a discussion and a friendly discussion, and we usually come to some consensus. So the next two cases are complications submitted to IMCAS Alert with injectables containing calcium hydroxyapatite, CAHA. And as we know, that's an injectable agent that can improve collagen type 1 and 3 ratios, elastin, and proteoglycans. So the first case was a case of a question as to whether sodium thiosulfate can dissolve Harmony CA nodules. So we're not using brands, but this is how it was submitted. And it was submitted by a very well-respected, long-standing IMCAS colleague, Professor Bertolt Chani, and this is the summary of his submission, that Harmony CA was injected into the jawline, that the patient developed hard, non-inflamed nodules, and the patient actually had done the internet search already and had read about sodium thiosulfate to treat the nodule. And so Dr. Chani was asking for help from colleagues as to whether people have had experience with that. And Dr. Weiner, who's here, was one of the first to respond and basically said, not very good. I wouldn't use it. And then we had Dr. Azoulay, who also sort of agreed with that, and Dr. Rivkin, who also agreed. So they put paid to that exercise. And Dr. Hamadani, who's already been referred to by Dr. Rappel, responded saying that that he had tried sodium thiophosphate years ago, and unfortunately was zero improvement. But in his experience, Harmony CA is significantly less forgiving than Radies, so sorry about any commercial interest here, but that was his opinion. And management often requires patience and a layered strategy rather than single intervention. And he outlined that he normally tries to disrupt any nodules with saline or water, and ask the patient to put on warm compresses and perform foam massage. And this step is important, as many assume won't work, but can work. And in a very inflamed nodule that's hard and not responding, he will start to use the combinations of perhaps 5-FU and triamcinolone, and in different concentrations for large. And this is a slide that you might want to take a photo of, because this is a summary of Dr. Hamadani's treatment, intranodular treatment with 5-FU and triamcinolone. I think it's a very worthy slide to remember. So case 2 was also calcium hydroxyapatite. This is a case, and you can see on the screen the nodule in the neck, and I'll summarize that. So Radies, CAHA, was injected into the neck by a colleague. This was presented to this particular doctor, and nodules developed that a colleague had injected, or this colleague had injected 3 times with steroids, intralesional steroids, with no improvement. It feels like too much was injected, and the author sought treatment, and with suggestions apart from excision. So I borrowed from Dr. Rosa Sigrid's paper here to show what this can look like on ultrasound with another case. And as you can see, I think in the center there, the nodule of calcium with enhancement posterior to that, shadowing, I should say, posterior to it. And this is what you might see on ultrasound. Ultrasound today, of course, is very important tool that everyone is having in their office. So there's no reversal agent for CAHA as such. And for these cases in the neck, they can be very problematic. And in fact, Dr. O'Shea, who is a very, very prolific responder, and she suggests that, in fact, these biostimulators in the neck are a lot less forgiving than one can imagine. Dr. Hamadani suggested that the majority do not go away, and that he's had patients with nodules for 4 to 5 years and they've tried everything from CO2, erbium interlesional laser, 5-FU steroids, and they are left with chronic pigmentation sometimes after those interventions and fibrosis. This is the truth. I have cases to prove it, he said, and with PLLA as well. This is why I never inject these products in the neck. And this was the experience. So a structured approach to treating calcium hydroxyapatite. Level 1, natural degradation, some of them do go away. Interventions such as mechanical dispersion techniques are preferred due to their efficacy. And at level 2, interventions offer alternative modalities, including pharmacological treatments that I outlined, and lasers. And then the last resort is manual removal or surgical excision. So determining the efficiency of barbotage. Now, one of my colleagues, a radiologist in Sydney called Mobin Master, at a conference last year in Sydney, suggested that one of these manual techniques that he likes to use is borrowed from the techniques called barbotage used for, guess what, calcium hydroxyapatite tendinitis in the shoulder. And I think, Steve, you've sort of resonates with you a little bit, this technique. And so I'm going to play a quick video. If we could have the sound up, please.
Picture, what you can
So this is
see
borrowed from
is
rheumatology or
directed
orthopedics.
ultrasound guidance, so that it penetrates into the calcium. Once it's there, that's when the magic occurs. What we can see in this case is that we're pumping some fluid into the calcium deposit, and by pushing in and pulling out, I'm actually drawing that calcium out. I'm going to emphasize that even more on the next picture.
So this
Again,
is what we
can
might
see
like to do in
calcium
our
fluid going
field.
in and then the material pulling out. Let me show you what this actually looks like in terms of the syringe. This is going to be the fluid before we put it in. This is a numbing agent called lidocaine, and you can see it's a very clear liquid. This is going to be the fluid afterwards. I'm not sure if you can see, but it has powdery white calcium deposits that we basically pull.
So that's your calcium hydroxyapatite. So basically it's a little bit more aggressive flushing technique. Leonie or Rosa, have you used this technique in your work? Steve, I know it resonates with you a little bit. Have you used it in your work so far? Give the microphone on, please.
I haven't done the aspiration aspect, but what I do is I flood it with saline, lidocaine, and hyaluronidase. And a needle works better than a cannula. And quite frankly, all of the nodules that I've had with CAHA or been referred have responded to that. I haven't gone the next step. I've seen disastrous results when steroids have been injected. I mean, we have seen it where the patient has a significant lesion that cannot be helped. Depressions, atrophies, so forth. So I think that 5-FU is a good alternative if you're, but I would give it 3 or 4 times with the barbotage until, and let me just say one other thing about the, what's the dissolver that's promoted?
Sodium thiosulfate.
Yeah, thiosulfate. I approached there's a woman and a doctor who patented that technique, and she no longer recommends it. Okay. So,
that's great. Can I just go along the panel? That's my talk actually, but I'd like to go along the panel. Dr. Schalke, do you use what technique do you use for these hard nodules? Not one in the neck like that. Do you think you can get rid of that?
So one of the problems, and this is what you also see with ultrasound, is that people don't realize you only have 1 millimeter on average to inject in the subcutaneous layer. It's very thin in the neck.
In the neck, yeah.
You have a lot of room in the décolleté. You hardly have any room in the neck. So it's misplacement, that's one. And I do your technique, but Steve is better than I am because we don't have a lot of responders. For PLLA, it does respond. So we do hyaluronidase. It disappears, but you have to get in the nodule.
So you need a needle.
You need a needle,
not a cannula,
but you need an ultrasound as well.
Yeah.
Because if you do it ultrasound guided, you see that your needle and your cannula is slipping off. So if you do it without ultrasound, you think you're in the nodule, but you're actually slipping off that nodule, and it's a lot of effort to get your needle in that deposit and then inject.
Yeah.
But I don't have with I don't have that good of a result. No, it's not really disappearing. Is it in your case?
Yeah, but if it's early, yeah, that's the difference. Yeah, and the other thing, I think within the first 3 months or so, I think that some people call it subcision, and I think that's a wrong term. You're not, subcision is breaking up a collagen fiber that causes cellulite or acne scar.
Yeah.
But other people are misled too because they just inject and they don't do the mechanical destruction. That's really the meat of the matter. Is,
Yeah,
is
I think
getting
that's
in
where the
one
barbotage
hand
comes in. Yeah.
and barbitaging.
Be a little bit physical about it. Dr. Sigrist, have you got an opinion on this at all?
Yes?
Yeah,
Yes.
yeah, we're here.
Well, I don't see the good results with that. But when we are talking about nodules in general of biostimulators, I see a lot of nodules. And what I think, this is an opinion that I think many people, I think you agree with me, but patients get so anxious about those nodules and they want to have something done. And I usually say, please wait, let's wait. Because if it's only palpable, but you cannot see it really well, I advise you, don't touch it.
Are you talking about all biostimulators, PLLA as well?
PLLA,
Yeah.
CAHA, or PCL.
Yeah.
And people want to inject and they do atrophies. I see terrible
atrophy,
cases
yeah.
because they come to me with those nodules with atrophy, hyperpigmentation. So I think...
So there's a lot of nodules in Brazil. There seems to be a
lot
lot
of
of coffee in Brazil, but there's a lot of nodules in Brazil as
Yes.
well. Maurizio, have you got a view on this, please? You can pass the microphone if you like.
So I'm very conservative when it comes to injection of those nodules with steroids because of that problematic atrophy. So I really try to avoid that. But when you have a nodule that is visible, palpable, and the mechanical dispersion or mechanical destruction does not work, I give it a try. I also mix it with hyaluronidase, but I just put 0.1 ml of triamcinolone of that 1 ampule,
yeah.
that is 10 milligrams per milliliter.
Yeah.
And the 5-FU, if I have to inject 5-FU, I just put also a very small amount. And when you mix that with hyaluronidase, right, the hyaluronidase will also improve a little bit the dispersion. So that's actually the rationale of using it with hyaluronidase.
Yeah. Can you quickly describe for the audience the ultrasonic features of something like...
Oh, yes. So when you use ultrasound for this, it's good to locate, of course, the location of the problem. You will see it's maybe in the fascia or subcutaneously, and then you have to use a robust injection instrument. Use a needle, a 25 gauge needle at least, and a little longer, so you have a more stable injection, and then you approach the nodule in a in-plane technique and try to inject inside that hard thing. Sometimes you really have resistance. When you have the resistance, that's the right place. If you don't have resistance, the solution is going away somewhere else.
Dr. Wan Lee, have a remark from you on this topic. It's very important because patients are very anxious, especially if they're inflamed. Okay.
I mentioned in IMCAS Paris like 2 years ago with Marina. Why are you using CAHA? It was the point. I mean, for the radius, like 10 or 20 years ago, we were using that thing for volumizations, right? But suddenly it became the biostimulator and injecting to the subdermal layers, right? And the problem is that any biostimulators that we call a uh, synthetic polymers such as CAR, PLLA, PDLLA, PCL, all those should inject to the dermal layers to stimulate fibroblasts. That's my idea. If you inject to the subcutaneous list, there must be foreign body reactions. And if it prolongs, then there might be a nodule formation, right? So if there's now nodule which is very hypoechoic, then it means that they have a fluid inside. It's good. Then after that, you can use hyaluronidase, you can use triamcinolone or any other things. But as I'm a plastic surgeon, I'm looking for the is it scarless incision possible or not? If it's so, the thing is that we doctors should not think about by injecting solve the problem. It might have operations. It might have injections, but you know, it's, if you inject more and more, and patients feels more discomfort and it doesn't disappear and so on. So sometimes it's a very when we do the operation, it's like a very hard fibrosis nodule sometimes. So in that case, nothing is effective, right?
Dr.
So
Lee, we have to move on. Thank you for the very good answer. Thomas, I don't think you want to talk about this, or you're happy to contribute in any way? Or?
One word, I do the same like Mauricio.
Yeah.
I also use hyaluronidase. I think it helps.
It helps
Yes,
disperse it.
exactly.
And a bit of barbotage, a bit of aggressive. Yeah. Our next speaker. Thank you very much, everybody. It's very insightful, and we're all learning. So our next speaker is Dr. Maurizio Ceron. And Maurizio, you're going to speak on the essentials of effective dissolving. What a segue. It's perfect. There you go. Thank you very much.
Oh, I have a little plug. It's great to see that everyone is still here, even if it's 5 p.m. And that shows that you are good practitioners willing to learn about complications. Does it work? Good. We know that hyaluronidase, when we use this, that can become a real headache. So I'm going to share with you a very simple approach in order to make it easier for you and for your patients. This is my disclosures. And this is an image of two patients that I get to see almost on a daily basis. They have been injected over the last 15 to 20 years, mostly with HA, and they come seeking for help because they hate how they look on photographs. They hate smiling. Their husband and friends tell them they look different now that they have aged, and they are scared. Why are they scared? It's because they have been consuming a lot of social media on hyaluronidase and a lot of wrong informations around this product. So how to navigate through this dissolving process, and I'm talking about the elective dissolving process, not the emergency one. So this is an approach that I will concise into 5 key points when it comes to dissolving. And the first point is know your hyaluronidase. This might sound basic and obvious, and these are the most relevant publications on this. However, we have to know that we don't have real solid literature on this, and with that I mean randomized controlled trials and meta-analysis with a real backup on the effects of hyaluronidase on facial tissue. We have, rather than that, a lot of expert opinions, we have experiences, so we have to do our homework and learn about the single product that you will use in order to treat your patient to dissolve the filler. So I'm not going to nerd out about how hyaluronidase work because I assume that you know how it works. But what I will recommend here is that you have a lot of information about how to use the product that you have available in the country that you work. We have many different hyaluronidases out there. In Germany, we use hyaluronidase Dessau. Here in Thailand, Liparase is very popular. And the problem here is that sometimes people inject hyaluronidases that are not supposed to be injected in tissue. They contain lipase, proteases, even botanicals that might also cause more side effects. And just read that package on the information leaflet when you use your hyaluronidase, and even have a talk to your pharmacist in the pharmacy about this product. So we have different products that are used in the USA. 3 are approved for facilitating subcutaneous fluid infusion and enhancing absorption and dispersion of drugs, etc. However, when we use it in the aesthetic realm, it's off-label use. Never avoid telling your patient about this. So you have to inform that it's off-label use when it comes to getting rid of filler. And there is one point about the allergic reaction. It's actually most of the time a misinterpretation about this. And this is a very, very rare complication from hyaluronidase. And the only one real allergic reaction that have been published, it's around 4 to 5 cases. And those cases are related to IV injection of hyaluronidase for another indications. And transpassing the units of over 100,000 units. So we don't inject this amount actually for the elective dissolving. And I see people claiming about, yes, before I dissolve you, I will do a skin test. However, we don't have validated tests in order to make a proper interpretation of a possible allergy. So more important is that you know if there is a history of an allergy, or if you suspect that there is an anaphylaxis to hyaluronidase or wasp or bee sting, then you will refer your patient to a real allergy specialist and not perform this intradermal test. Now, the second point is know the filler. And when I say this, of course, the type, brand, amount, I know this is something very difficult because most of the time patients don't know what they have had injected. However, you can see the filler if you use an ultrasound. And there are plenty of studies about this, and also different fillers have different responses to this medication. So it's better to see the product rather than guess what your patient has down there below the skin. So if you summarize those publications you just saw, you will find that the cross-linking is a very important factor when it comes to dissolving filler. For example, if you have highly cross-linked fillers, they will respond less than a less cross-linked filler. And when it comes to the dissolution speed and treatment strategy, we have the biphasic fillers that are gel particles embedded in one gel matrix. Those dissolve a little faster, and with lower hyaluronidase doses, we have some recommendations out there that claim 100 to 200 units per area. I'm going to talk about this later. And the monophasic fillers are these homogeneous gels. They normally need more hyaluronidase. And if you inject hyaluronidase into a filler nodule, you have to be inside the nodule and not around the nodule, because the hyaluronidase won't make the work from itself. It won't swim inside the nodule and open the capsule and then make the magic. So you need to have contact between the enzyme and the substrate in order to have a reaction. And the vigorous massage is also recommended in order to optimize the physical contact. This patient came to our clinic. She had malar edema. She didn't like how she looks when she smiles, obviously. And my ultrasound showed me the following. In the area of the under eye, in the cheek, there was filler, very superficial, but also in the fascia. And in the nasolabial fold, there was something different. I asked her, what is this? And she said, nothing. I have never done nothing else except of HA. And then she said to me, oh my gosh, there was this lady 35 years ago. She injected me with silicone. And that's it. That's actually how silicone looks like. And that's the nasolabial fold. So I didn't do anything around that area and left it. So I dissolved the under eye and the cheeks, and she looks better. Well, she still has the silicone in her nasolabial fold, but I was able to tailor my treatment thanks to the ultrasound guidance. Now, know your patient. This also sounds very basic. However, you have to make your consultation as good as your results. Take your time. That's actually something that I really recommend. And of course, the filler history, medical history is important, but I like to ask the patients this open-ended question. What was the goal of the treatment? Here you will be able to understand if your patient is guilty of his outcome, because most of the times, or in many occasions, the injectors are actually the ones that are causing the problems. And then you will notice some body language messages from your patient. You will be able to read the patient and to see if actually they understand what is going on. So active listening is also important in order to identify red flags. What do I mean with red flags? I'm talking about body dysmorphic disease, because you will always, you might have confrontation with these kind of patients. And these are the 5 most quoted sentences that patients with BDD will tell to you. I can't stop thinking about this tiny lump. No one else can see it, but it's all I notice. That's preoccupation with a flaw that others don't see. Other practitioners told me it looks fine, but I know there is something wrong. That's persistent dissatisfaction. That's not a physical concern. I keep checking in the mirror, and I can't move until this is fixed. Compulsive checking, obsessive behavior. I need reassurance. Are you sure you can make it perfect again? Constant reassurance, and also unrealistic expectations being around. And I have to have this gone. It's ruining my life. Deep emotional disturbance. So be aware when you hear these things. And when it comes to injection techniques, our 4th point, discuss with your patient about different techniques. So when you see this woman, she has swelling, she has edema, and she's of course annoyed by it. And you will ask yourself, well, where is the filler? What should I dissolve? And when you do an ultrasound, you will find that, I don't know if this is working, no, the laser doesn't work. However, you see that all of these blackish, round-shaped, oval-shaped deposits are actually everywhere, in the area of the tear trough, in the under eye, around the infraorbital foramen. And the 3rd image below, it's in a vertical position, and you see the deposits actually everywhere. Now, what did I dissolve here? I dissolved the more superficial located HA. Do you see the here? This one is actually what you see here around this area. And also, all of the material that was located compressing and disturbing the flow at the area of the infraorbital foramen, and I mean the venous outflow. So after 2 sessions of very cautious dissolving, I never use more than 10 to 15 units per deposit in the infraorbital foramen. Sometimes it's too much. So you have to be aware that dissolving around the under eye, you really need to keep it very brief, very low, not so much. Don't put 100, 200, 1,500 units, because this will also cause more problems, and your patient is going to be very anxious after the dissolving process. And last point is the patient consultation. Now, you have to talk about the factors that will influence the dissolving process. And it's about the type and amount of filler. You have to know HA versus HA, of course, the amount that you want to dissolve, if you have 0.5 or 20 ml that you want to get rid of. and also the type of hyaluronidase that you will use. Is it an animal-derived or not? Is it licensed for the injection or not? And let the patient photograph the product. I am very transparent with my patients, and I let them really photograph the medication, and I tell them I injected X, Y amount of units in your face. And the injection techniques, again, we know that ultrasound-guided hyaluronidase injection will lead to a better outcome, to more effectiveness, because you're working inside the problem when you inject intralesional, and you will need less amount of hyaluronidase, which will lead to less side effects. And when it comes to the consultation, again, the wording is here something very important. We know that hyaluronidase does not really work like an eraser. It modifies the filler. We are injecting this enzyme in a complex filler tissue system. So even if the patient might have a clinical improvement, you still will be able to visualize filler under ultrasound. So we are not dissolving, actually, we are modifying filler. So this is actually the more honest, scientific, and clinically safe language. So what we communicate to our patient, how we educate them, is also going to play a role. I like to make this analogy when we use hyaluronidase. It's like a wave, and it comes after the first wave, you still have some there. And maybe after 3, 4, or 5 waves, the floor is going to be even. This is an analogy that you can talk about with your patient so that they understand that one single session might not be the solution for the entire problem. And if the patient wants to go legal against you, these are the must notes that you have to write down in your informed consent. Off-label use, the breakdown of HA, if needed, multiple sessions, the point about the allergy, a possible volume deficit with correction at extra cost, and possibly no effect. Everything you write down is what is going to save you when you go to court. And extra recommendations here, have a plan B. Use energy-based devices. We have protocols on radiofrequency microneedling, CO2 laser, even endolaser. Or be brave enough and refer your patient to a facial plastic surgeon, oculoplastic surgeon, or even to a psychiatrist, because we have really effective therapies when it comes to body dysmorphic disease in terms of behavioral therapy and medication. So these are these 2 patients after the filler modification looking more natural. And these are the 5 points, again, that we just went through. So if you want to learn a little bit more about ultrasound, feel free to scan this QR code, and I'm happy to be your guide. Thank you.
Thank you very much, Maurizio. Great talk. Thank you. Thank you very much. Just a thank you to Maurizio. We'll have some question time at the end. Yeah, please. We'll have some question time at the end because we're running a bit behind. I'd like to introduce our next speaker. I think he's somewhere here, Dr. Amit Luthra, who is a dermatologist from India, correct, Amit? And we're going to, he's going to speak on 2 extremes of filler complications, vascular and allergic, a tale of 2 cases. Thank you, Amit. Thank you very much.
Okay. Projection. Good afternoon, everybody. It's a pleasure to be at IMCAS. First of all, the usual disclaimer. If you're not terrified enough, I'll probably scare you more so that you can't sleep tonight. I've got 2 cases, and in fact 2 series rather. So they are kind of 2 extremes that you might see in your practice. And it's a tale of 2 cases, and this is something that I experienced firsthand. So let me kind of tell you about it as well. I'll take the first 2 cases and kind of bunch them together, just wanting to drive home a point that you can use hyaluronidase any time or every time that you need for HA fillers. This is a patient who was injected, Indian patient, came to Thailand for a holiday, injected with a needle into the lip, and the doctor notices blanching. She stops injecting. Hyaluronidase is used to dissolve the product the same day and the day after. Patient has a flight to India, so obviously cannot stay. And then the patient lands up in India. In fact, we opened the clinic at 9 in the night, and she came from the airport directly to the clinic. And this is how she presented impending necrosis that you can see. If you don't kind of stop it here, obviously there'll be problems there. So we kind of went about dissolving it, used a vial, which is 1,500 units on day 1, went up to 3,000 units, and then we did the same thing the second day, and this is finally at 48 hours later. We managed to recover her, and then we followed up, and she was quite okay, as in there was no scarring, nothing happened. So this was the good part of this particular complication. Now, vascular compromise, just to run through, there are areas which are most at risk. We are taught that glabellar region, the nasolabia, the nasal tip are the ones, but you can get vascular occlusion at strange places. You saw this in the lip. You will see another case of mine where we actually got it into the cheek as well. What is the way to minimize the vascular compromise? Obviously, you should know your anatomy well. One important thing is to aspirate, but negative aspiration does not guarantee safety as well. How do you manage it? Obviously, you should know these steps. You obviously stop injecting immediately. You got to administer hyaluronidase as fast as possible. You do not aim for intra-arterial injection. The hyaluronidase can cross over into the vessel, I believe, and you have to use high doses. There's an ACE guideline which you all can refer to. You massage the area very well, and I'll show you in my second case where massaging really helped. Apply warm compresses. Nitroglycerin paste we don't use anymore. Aspirin is important. What is the dosage? You give the patient 300 mg stat and then give her 75 milligram TDS along with antacids. And this is what we used in the second patient that I'm going to show you. You do have to use steroids sometimes if you're suspecting swelling causing some sort of extravascular occlusion, which you might think of in my second case. So management is kind of simple in the sense that it's a kind of systematic thing that you have to follow. And what are the proposed mechanisms? As I said, intravascular, extravascular, and vascular spasm. So look at my second case now. This is a patient who came to me injected into the tear trough with a cannula, not a needle. No immediate pain or blanching. Patient complains of pain later in the evening. And this is the picture that she sends me in the evening. And she's developing that typical blanching that you see. And this is the point where I started the cannula, as in the entry point of the cannula was here. And she had all over. You might wonder as to what vessel was involved, probably some branch of the transverse facial, or was it the infraorbital, some branch of infraorbital. We're still not sure. Anyway, the point is she presented with this kind of blanching. We called her into the clinic. She refused, and then the story began. She said, I can't come into the clinic. This is around, 10 p.m. in the night. I said, you come into the clinic, we'll open the clinic and do it. She said, no, you can't do that. I said, I can come down to your house if you want. But she said, no, my husband doesn't know about it. So you can't just walk into my house and start injecting me. So that was the tricky part. Anyways, I told her to start using warm compresses. I told her to start aspirin. I put her on steroids. And then we decided I'll do it the next day morning as early as possible. So next day morning, and this is happening throughout the night, I'm on the phone WhatsApping her. 2 a.m. in the morning, she switches off her phone, and I'm still awake trying to get through to her to make sure that she comes into the clinic. Finally, 6 a.m. I see her online, so I call her up. I said, you got to come into the clinic as fast as possible. She says, I can't. I said, why? She says, I'm actually at the airport. I said, where are you going? She says, I have a flight. I have a group flight. I'm flying into the Himalayas for a trekking. So there's a vascular compromise, and now she's going into the hills where the snow is. So I said, you have to cancel your flight. You can't do it this way. She says, I can't do it. I've not told anybody. So now these are the 8-9 days she's in the Himalayas. I try and trace a doctor who's close to that place, can't get a doctor there. My wife suggested that he should catch a plane and probably go there and do it. But again, the same problem was, how do I convince the family and the doctor? It is laughable now, but it was pretty kind of tough for me those 8-10 days. Anyways, point is, she comes back at day 10 with this scenario. And obviously, there is impending necrosis. She went through the whole gamut of changes, which we kept on doing. She was on aspirin, she was on steroid. Now, this is the patient again. See, when I press it on the area, she actually winces. That's where the pain is. And we managed to localize it and then started using the hyaluronidase. This is day 10. Now, the second video you see, this is my cannula going through my glove. This is a 25G cannula. Just wanted to show you the video so that you understand that even with the cannula, there's a possibility of intravascular cannulization. And it's quite easy to go through. it kind of easily slides through your glove there. Anyways, so we started dissolving this with hyaluronidase. Obviously, the rest of the things were done. This is 1 day after the dissolving when she came in. This is the 2nd day. And finally, she recovered with some bit of post-inflammatory hyperpigmentation and very small scarring, which we treated with a Q-switch and a fractional device. So ultimately, the patient was managed. That was one half of my presentation. And now comes a different case here. Now, this is a patient who came to me from the UK. She's a 73 years old, injected with 4 ml of brand A. I'm not taking the name of the brands. She was injected into the cheeks and chin. Very happy with the, whatever was done. Comes back after 1 month for some more. We inject 1 ml of that same brand again into the chin apex. And then since we run out of that product, we take a brand B into the nasolabial folds and the mental crease. And 2 ml of a booster was put into the neck and a little bit into the mental crease. So it's a kind of a complicated scenario that we are in. This is the patient before and after when she was happy with the product at the first time. This is when she came in the 2nd time. Now, if you notice in the 2nd picture on your right, you can notice the bruising. Obviously, a cannula was used. Can you see these small blisters on the chin? So our first reaction was, is it herpes labialis that she's got? Is it a vascular occlusion? Is it an allergic reaction to something in the product, the BDDE or any other ingredient? Or is it an interaction between brands B and C? Because that's the area where the brands B and C were injected. So this is the patient on day 31 and 32, oral corticosteroids and antiviral. The very next day, the blisters disappear. So obviously, it was not a herpes infection. Probably it was either the vascular compromise or some sort of an allergic reaction or the physical impact of the products put into that area. She was managed with the oral corticosteroids. Remember, if it's an allergy, you can't do it only with antihistamines. You have to put in corticosteroids to the patient. She was quite itchy, incidentally, all around, in the sense her face was quite itchy, and that was what she was complaining. Finally, she settled down, and this is again finally the settlement at day 36. Then she kind of gives me a history when we kind of go back. She's okay now. She tells me that she's lactose intolerant, she's gluten sensitive, and allergic to MSG. MSG is monosodium glutamate, which we know as Ajinomoto. Why is it important? Because the 2nd round happens after another 15 days. She has her Chinese food in the night. She takes some seafood and suddenly swells up again, especially in those areas, the nasolabial areas and the mental crease areas. And day 51, again with oral corticosteroids managed. Then I went back and searched for these 2 brands. And what I realized, what brand A and brand B, there was some difference here. Brand B had disodium phosphate and sodium phosphate monobasic dihydrate, which brand A did not have. We went into the research, and then what we found is disodium phosphate is an emulsifier which is used for cheese, cream, milk products, and this is a rare allergen, but it may cause allergic reactions. It causes hives, it causes itching, and though it is not directly related to your MSG allergy, individuals who are allergic to MSG might respond or might kind of react to this product if it's there in the filler as well. Finally, again, we managed to get her down with oral corticosteroids. What you see on the right side, we did a dermographism test. I wanted to do an inoculation just to confirm, wanted to put a little product, but she refused to do it. So this was primarily a hypersensitivity reaction to one of the ingredients of the filler, and hypersensitivity reactions are Ig-mediated reactions. You'll have to manage, as I said, with corticosteroids. Some bit of antihistamines would help. It's a foreign body reaction which can last very long. It starts actually quite late, but it can go up to even up to 6 months. And the response is definitely with your steroids. You might wonder as to why did I not use hyaluronidase. The patient actually refused. And with the kind of profile she had given, the allergies, I was a little skeptical of using hyaluronidase. Ultimately, it settled down with the corticosteroids and hypersensitivity reaction. I hope you have a good night's sleep today. Thank you.
Thank you so much. It was an excellent presentation, and I think we learned a lot from that. Now it's my great pleasure to invite Kuldeep Singh, also from India, Delhi, plastic surgeon, talk about toxin, new indications. Thank you very much, Kuldeep.
Thank you, Thomas. And after all the scary things, some little comfortable things. We normally use toxin for regular indications, which we all know. But I think as a plastic surgeon, we get a lot of, yeah. So, this one? Okay. So you need these two things for efficient and judicious use of toxin: good functional anatomy knowledge and good experience. Once you are comfortable, you can do all the conventional aesthetic indications, but then many times you are faced with unconventional situation, like a developmental asymmetry, a post-traumatic asymmetry, or it is iatrogenic, or post-infective, or it is caused by earlier attempts at correction. So, like this is developmental asymmetry of eyebrows. Another one, this is, she had an accident, a scar on the right side, so that eyebrow, which is good, is actually the scarred one. This lady had an attempt at making a dimple on the left side, got a buccal branch in that. This was a colleague, and she said, I have an asymmetric smile, and can you correct it? Another patient, I'll come to this, a child we operated 1 year of age for a transverse facial cleft, and at 10 years she turns up, and they say that the smile is asymmetric and the resting commissure is also asymmetric. Another patient, Bell's palsy, recovering, now facial asymmetry. So this was my first patient. He said he had this eyebrow, and we thought we could do it, correct it. He said, if you can, do it. So we tried to drop the frontalis and raise the medial end of the eyebrow, and it worked. And you can't tell unless you ask him to raise his eyebrows. Then you can tell there's a difference. Now this patient, and we said we must modify the normal side, raise the arch of the eyebrow, and drop the medial end. And I didn't know still whether it would work, and it worked, and we could get symmetry. So you're getting confident, and sometimes that gives you a little false confidence. Now this patient, there's a buccal branch injury on the left side with hyperactive muscles on the right side. If you can see her talking, and it goes up. And so what we did was we tackled the normal side, the hyperactive side, the levator labii superioris, the zygomaticus major, and the peripheral part of the orbicularis. And this was she at 2 weeks, and this is when she was talking. And if you see the little compensatory hypertrophy of the left, hyperactivity of the left aleck I will caution against that to get a perfect response, because you can get into trouble. And so next time I tried, no, it was not effective. There's another patient with Bell's palsy with right side residual paresis. And again, if you see, the rhizorius is still very active compared to the elevators and the depressors of the lip on the right side. And so we thought we'll just treat the left side, the aleck the levator labii superioris, the zygomaticus major, and the DLI. And we got a fairly good response, but when she came, she said the angle of mouth right side is still pulling. And so we tried to give a little in the rhizorius, but that was dangerous because it pulled the thing it blocked the normal too much. So I caution against that. Now this young lady, she came to me again. So if you see here, the right side is the paralyzed one. The left side, angle of mouth, the resting commissure is oblique. You can see the zygomaticus major, levator labii superioris, DLI, all of them acting more, but the right DAO is very hyperactive, the affected side. So we tried to catch that, and the orbicularis, once it is hyperactive, actually makes the vermilion quite thin. So we did this, and the resting commissure improved. Her smile got better, the DA is fine, but her rhizorius we did not treat, and that is still more active. And I have just given her the rhizorius. I will tell you, maybe later we can discuss. But see her smile, maximal effort is good symmetry. This patient had a dog bite, right lower lip, And the right rhizorius, the right DLI, they were both weak. The left one was actually hyperactive. So what we did was the left side we treated, her DLI and the DO both. And if you see her, the smile is better. The rhizorius actually is kicking in much better. So if you have a weak muscle on the affected side and you weaken the normal side, you will still see it getting more effort. And I'll show you in that young girl who came later. I'll just go to that. And we did some filler to improve the vermilion volume on that side. Now this was a little difficult. Her resting commissure also was a little more pulled to the left and on smiling much more. And here it was difficult, it was a colleague, so I thought I'll just put 2 units in the left zygomaticus major. You see the resting commissure, you see the smile. And then there was this young girl, and her right angle would go up, so we thought possibly the right zygomaticus major has unopposed effect, and that is why it is pulling it too much, but there's also the levator of the upper lip also kicking in. So what we did was, we managed to inject into the right zygomaticus major and in the levator labii superioris. And if you see here, this is the top you see left side before, right side after, resting commissure, smile, the levator labii superioris, on smiling, on full showing of teeth. But when she came to me after 6 months of the last sitting, and I saw her, I saw that she had recovered and she did not need any more toxin, and possibly the muscles were not strong enough. Now they've got a chance to develop. If you see her smile and if you see her teeth, it has become much better. So I stopped injecting toxin in this. This girl, she is 16-year-old, she is a weightlifter, and she had congenital absence of the right platysma. And therefore, when she smiled, the left platysma, the DLI, the DAO, all of them were very active. And you can see the bulge in the left side neck of the platysma, nothing on the right side. So we injected her platysma, the jawline, the DAO, and the DLI. And this is what she was post 2 weeks. Much better in terms of smile, nothing pulling in the neck, but still a little hyperactive DLI on this side. And this patient had hemifacial spasm treated by a neurologist. She said, earlier I had spasm, now I'm paralyzed on the left side, and her left angle of mouth were going down. She was very upset with the drooping of the left angle of mouth. It was like this. And then it was difficult to get her to inject more. She said, 1 injection, I've gone like this. So anyway, we injected 2 units into the left DAO, only that. And that got her smile asymmetric. So now I do all my hemifacial spasms and balance their face at the same time. And this is her smile, horizontal, and a little difference, but yes. This patient is post-surgical. She had multiple surgeries, and she has some paresis on the left side. You see her columella deviating to the right side, the philtrum gone to the right side, and the lip completely asymmetrical. So here what was the problem was the left levator labii superioris, the DLI and the zygomaticus major were weak, but like I said in the other one, the right DAO was hyperactive. The left rhizorius was hyperactive despite being the weaker side. So we injected the right side, we injected in the levator labii superioris, the zygomaticus major and the DLI, but the mentalis injected in the midline. She was using it too much, and the left DAO and the rhizorius. And this is, if you see after 2 weeks, the philtrum has moved closer to the center, columella is less oblique, and when she smiles, you will see a much more symmetrical smile. When she shows her teeth, more horizontal smile, more centered, and the teeth showing more uniformly. Some places you fail. This one I tried, we could do nothing. It was almost the same with slightly increased arches. So to summarize, in developmental asymmetries, we do ipsilateral correction. In post-traumatic, contralateral. Same for facial weakness, but in facial weakness, you can see a compensatory hyperactivity of some muscles on the weak side also, so you have to be careful. May have to fine-tune dosages. The most important thing is, I mark the charts myself, exactly where I have injected. I do not use ultrasound. Yes, it would be more effective, But I think, so because replication and consistency is important, in my hands it may be effective, but yes, that should be done. And in the mid phase, the non-paralyzed side is very strong and needs higher dosages. Should document dosage and injection points very diligently. Static and mild animation is easier to achieve, but severe animation you cannot, and if you try to do that, you will lose everything. And don't do overbalancing. Thank you.
So we had some great speakers. Thank you, Dr. Kuldeep Singh. So now we're going to open up, I think, to the panel and the audience. This is a very IMCAS alert is very interactive, so it's appropriate that we do open up this. Dr. Weiner?
Yeah, I wanted to just make some comments on Mauricio's. And one of the things you said was dissolve at the beginning. And Steve Harris and I wrote that paper about modifying, and I think that that's true. And it's really important because the patients say, you know, I want it all removed, and we can't do that in multiple sessions. The other thing that I think, you know, hyaluronidase doesn't work at the cross-linking. And you said it's directly related to cross-linking. I think it's more related to the manufacturing process than cross-linking. Like the Juvederm and Voluma, their manufacturing process is a little different. Because if the hyaluronidase has a hard time getting into the HA product, I think it becomes harder. And there's obviously a lot of studies showing which ones are harder and which ones aren't. And it's not only cross-linking, it's the manufacturing process too, I think.
But what do you refer specifically with the manufacturing process? Because cross-linking belongs to the manufacturing process, and we know that the companies have different technologies of manufacturing. So we have Bicross, we have CPM, we have NASHA, we have BTM, we have so many different things.
Yeah. But I think
so
I don't think it's as simple as the cross-linking. I think it's
true.
It's the process that it was manufactured. And then the third thing, and just to hit home what you said about the tear trough, and to be very gentle in that area. And I wanted to expand upon that because what happens is the tissue gets expanded from this chronic filler, and it's almost like a tissue expander. And if you modify it too quickly, then the skin becomes loose and saggy, and it's almost worse than if you didn't do anything before. So that's why your goal isn't necessarily to remove it all or modify it all. It's to get a better result, which means very gentle, like you said, 10, 15 units, and bring it down. Yeah.
Did you have anything else, Steve, that you wanted to bring up?
No.
We might open it to the audience. There are microphones available. This is your chance if they've got a burning issue. Dr. Singh has got a question for us, one of our speakers.
Yeah. So Mauricio, you said that allergic reaction is rare. I have seen a lot of allergic reactions, the first one being anaphylactic shock. And this patient went ahead and got another filler, and this time she was hospitalized, she was in ICU, she was primed with corticosteroid, Avil, everything, and she was sent home and she had a delayed reaction at home. There's one patient with the test dose, intradermal dose, she had massive swelling of the whole upper limb and had to be hospitalized. There are many, because these are all repeat high lasers. So I had another patient, many times high lased. She said, every time I get high lased, my face is swollen and I'm in bed for 3 days. We tested more than 20 millimeter induration. We primed her with hydrocortisone and she did not have this. We had a vascular complication and this patient had a very severe induration here on testing. We primed her again with hydrocortisone, dissolved her on 3 occasions. So I don't know whether I attract more allergic patients, but have seen a lot. So therefore, unless a patient says, they've been high-laced before and nothing was there, no swelling, then probably I will not do it. Otherwise, first time high-lacing, I always test, and maybe in 100 I'll catch 5, and that is okay because the ones I have seen were severe.
That's interesting. Thank you
Yeah.
for adding this. I think that having an idea of what kind of hyaluronidase you're using, I don't know which one do you have
So India it is
available
bovine,
in
yeah.
bovine.
Yes.
So some of those products that are out there are also containing many different things next to the hyaluronidase. And how much did you inject? How do you have an interpretation of if it's an allergy or not? That's the thing, because I dissolve on a daily basis at least, or I modify filler on a daily basis at least 4 to 5 patients. That's the normal, and I have never been obliged to do any intradermal test.
I think we need to publish,
Yeah.
yes.
Yes, we actually need to have more data on this on these kind of things, because again, there is a lot of hyaluronidases out there that people inject that are not even supposed to be injected into tissue.
We've also had a lot of, in Australia, we had a lot of people who were just using hyaluronidase like a filler. Like one of my colleagues once said, "Oh, my favorite filler is hyaluronidase. Anyone that comes to me, I just dissolve everything and start again." Well, you know, and that was before ultrasound was commonly used. So this is sort of, you know, people are having lots and lots of hyaluronidase, they might ultimately develop some problem too with indiscriminate use. And that's why ultrasound doses are so much nicer with low injection doses.
Yes, and I wanted to emphasize that the only real that I know from the literature, and this is actually something I know from Jillian as well, and Jillian is like one of the most informed person, and she does a lot of research on hyaluronidase. It's 4 cases on anaphylactic shock due to IV infusion of hyaluronidase for chemotherapy or something like that. And they use hundreds and thousands of units, so it's maybe also cost based on the amount that you use. If you inject 3 units of hyaluronidase, I don't know. Maybe how was your case of anaphylactic shock that you had in your case?
So that was like about 50 units on both sides. I'm talking about test dose also, and that was not even like 3 units is one division. So 3 units. What I'm saying is all those patients who have swelling after high lace, if you start testing all of them, you will be surprised that you will find many are allergic. And they just tolerate that because they know after high lace 2-3 days of swelling is there. But the ones which are negative have no swelling at all.
Okay, so we might leave that topic for a moment. Open to the audience. Is there anyone in the audience that would like to contribute a question or a burning issue that they might like to know? I don't think we have. So what we might do, Thomas, what do you think we might, we've got 10 minutes, and we might ask our learned...
I have a question to Dr. Singh. Can you navigate us through the entire process of the injection of the DLI and zygomaticus major, and I mean with that product, dilution, and how you inject that? What do you feel? What is the technique? I'm very interested.
Oh, maybe the microphone. Yeah.
So the dilution which I use is I dilute 100 units in 2 ml. So that is one thing, and in a tuberculin syringe, each division is 1 unit. And the zygomaticus major, I inject between the inferior edge of the zygoma and the angle exactly in the line of contraction, and I always get an effect. The DLI again, the orbicularis oris, I always inject in the pink part, the peripheral part, because that is just for volume. And the DAO, anyway, at the lower end, posteriorly, the posterior border, I inject there, just above the lower, the jawline. And you said DLI. DLI is, again, more anterior, but below the orbicularis oris. So,
landmarks.
For the DLI, no, roughly, it is roughly about, so it is anterior, it is exactly, so what you do is, you mark the contraction and you see the DLI where it is um, um, the tightest, and you inject it away from the lip, closer to the chin. So that is where you are nowhere close to the lip, at least 1.5 centimeters you will leave from the white roll. So because you don't want the orbicularis.
And how do you avoid the modiolus when you inject the zygomaticus major muscle?
I'm far away. I'm midway between the, when I smile,
Okay.
I'm midway between the inferior edge of the zygoma and the angle of mouth. So I'm far away from the modulus. And I think not doing an ultrasound is a blessing, because if you are near the muscle, very little will diffuse, very little effect. I think wherever I have managed to hit the muscle, the one I showed next time, it blocked the muscle much more intensely. So, I don't know.
Stephen. Thank you, Dr. Singh. Thank you. Thank
I'd
you,
like
Marissa.
opinion of the panel and everyone attending. I routinely give prednisone for vascular occlusions. I think that it benefits the patients, unless they have skin breakdown and so forth. Do you guys give steroids routinely?
Not for every vascular adverse event. We give it in cases of biostimulator fillers, and for the nose we often do that because it swells much more, but for a regular one, just aspirin and hyaluronidase.
No. I don't usually use prednisone. Sometimes I use prednisone for patients that go for modifying hyaluronic acid, and when the patient says that, oh, I have done it before and I swelled a lot, so then I give some prednisolone.
If the patient has been treated before by another practitioner and they throw thousands of units of hyaluronidase and massage and re-inject and they have swelling, they have edema, they have bugginess. In that case, I would give prednisone in order to reduce all of that reaction, reduce edema, and I give that in a tapering system, starting with 50 milligram and then going down, and maximum 7 days, not longer than that. But otherwise, hyaluronidase and aspirin, it's the way for me.
Dr. Wan.
Yes. I don't use it.
Dr. Rappel.
Yes, I use hyaluronidase, and I do the corticoid treatment only if there's a problem, like if there's massive swelling or if there's some reaction, not in the first row.
So we might, have we got a question somewhere? Please, can you come to the microphone?
You can go to the microphone.
Yeah, that's best.
First of all, thank you everyone for the wonderful discussions, very, very helpful. I wanted to ask your experience with any energy-based devices with, CHA or, any kind of permanent fillers. Like in India, we're now starting to get it, and we're, being very conservative with hyper-diluting it, but your experience with energy-based devices like RF, ultrasound, or second part of the question, also like if the Botox tends to, like toxin tends to, spread, or like the client is unhappy with the results, can we make it go away by doing these treatments like energy-based devices like RF, ultrasound? Will it be helpful? Like,
Stephen, we'll go along.
When they sterilize HA, it goes up to about 115 degrees Celsius for 15 minutes. When you treat with laser, you might get to be 100. And when you treat with RF microneedling, it gets to be about 60, 65. And that's only for milliseconds. So I don't believe that you get any destruction of any of the fillers with energy-based devices. And it does help with malar edema to contract and improve lymphatic flow and so forth, but I don't think it affects fillers. And then with toxin, I'm not familiar with anything that improves toxin. Saline does not. Bactrostatic saline does not work.
When you have very resistant malar edema and you have modified or reduced the filler bulk, and it's still a problem there, I tend to use endolaser, which is a diode laser which you apply below the skin, so in the superficial fatty layer, in order to heat the tissue, make it contract more. It may help with that, and I see fair amount of contraction, but it takes time until it really, really helps, and you might need 2 different sessions. With radiofrequency microneedling and CO2, there is some protocols. If you look up for Dr. Kami Parsa from Beverly Hills, he has a good case series about this problem. So he actually used this very much for patients with resistant molar edema. So I would recommend to have a look at that. Huh? It's just at least a case series. Of course, experience, there is no, yeah, you don't see it.
Help with the edema aspect. I mean, that he builds his whole practice on that. Yeah. Okay.
You would like to know what is happening, right? We do laser treatments for more than 25 years, I think. Malar edema is the most seen complication in our polyclinic. Even in the Erasmus at the university, we do have a lot of lasers. We don't see that very good outcome. We see outcomes, but not that I would say, oh wow, let's introduce laser. That's one. The second thing that you always need to tell your patients if they come for malar edema, they will get back to their normal eyes. So if they did it for hollowing, you also have a clinical desirable effect of the swelling. And you get rid of the edema, but you also get back to your normal hollowing that you had before treatment. And this is where there's something gets very disappointed about.
Okay, so we have time for one last question because we're really nearly out of time. So could you put your question, please?
Yes. I had a patient a long time ago. I put Voluma, and it looked fine. They caught a cold. They swelled up. I gave them antibiotics and steroids. It came down. A couple months later, they caught a cold, swelled up. Gave it again, swelled down. Then I finally said, forget it. I'm just going to inject hyaluronidase. I got rid of it when they swelled up. Never came back. They're like, I want to do it again. I said, no, you can't. I'm just going to try Juvederm. I did Juvederm, nothing happened. But I never did Voluma again. I don't know if there's any explanation for that.
Actually, we call that delayed inflammatory reactions, right?
Oh, okay. Well, how come one reaction to Voluma and not to Juvederm?
The thing is that as Steve discussed, it's we don't know the manufacturing process, right?
Well,
did you go to the any
one's a Vycross product and the other one's not a Vycross product?
I mean, did you? I've been to several HA filler company, and they are all different. We call that MOD, right? How BDD is attached to the HA. So what I mean is HA filler should have HA, water, and crosslinker. But we don't know how much the crosslinker attached to the HA, right? So we call that MOD. And this one, BDD can be impurities. So what I mean is we don't know anything about Voluma has how much has impurities, or other product has how much has impurities. So as imagine, BDD should be stocked very well, right? Crosslinker. But actually, it does not crosslink very well. BDD has a pendant type, which is not attached to between the HA and HA. And there are so many pendants type. That can be impurities and have some irritation to the patient's skin. So if patients has immunology status, such as when we do the COVID vaccines, or then it might be occurring the inflammatory reaction. It's kind of a very difficult process, but just to remember that not all the HA filler has the same impurities. They have very different type of impurities.
Okay, I think we have to. I think we have to wind up. Actually, is there something pressing you wanted to add to that?
That's it. I don't understand how a
Well,
cold could elicit it.
can I comment? We have a polyclinic for 15 years, 3 full days. In all those years, there was one hyaluronic acid filler that was actually removed for the market because it had so many adverse events, and that was Hyacorps. It was cross-linked 63%. Besides that, we see not any difference between any hyaluronic acid filler. And every year we look into our data, we also name the brand. We don't see a difference. So I know that there's a Vycross story. We use a lot of Juvederm, a lot of Galderma, a lot of everything. There's not one filler popping up with more adverse events.
On that point, I think we should end the meeting. It's now 6 p.m. And thank you all very much for attending. Thank you to our panelists, our speakers. I think it was most interesting, and I believe there's a cocktail party tonight, so some of you may wish to attend that. But thank you again, and have a lovely evening.